symptoms of sodium nitrite toxicity, understand the mechanism of it, and be able to select appropriate treatments. I guess a disclosure for myself, I'm not toxicology trained, just EM trained, but I have an interest in toxicology, so I work really close with our toxicology team. So I saw Frank was on this meeting, so feel free to put your input in here. But to get started, so we had this patient, she was a 23-year-old female who kind of rolled into our critical care bay without a call ahead from EMS, and, just was unresponsive. Story we got from EMS was that she sent a weird text to her mom, and her mom called in a welfare check. Fire had to break through some doors. She kind of barricaded herself in, and she was found unresponsive on the floor. Initial evaluation by our providers was patient was toxic appearing. She was unresponsive. She had really blue lips with an overall blue discoloration to her entire body. As you can kind of see, this is a picture of her foot. And this is one of our toxicology fellows, his arm, showing the difference. Her initial GCS was 7, and as our nurses were able to draw blood, they noticed that her blood was really dark brown and almost black, as you can kind of see up here in there. Her initial vitals were a heart rate of 130, respiratory rate of 27, blood pressure 84 on 52, and she had an O2 sat of 72% on room air. So thinking about this case, one of our nurses did have the time to just quickly look at her chart. Thankfully, we had her name, and he alerted us that she was just recently discharged from her inpatient psych stay because she had a plan to commit suicide via sodium nitrite ingestion kit she was ordering on Amazon. So he initially alerted everybody to that, and that kind of helped us, identify that's what this was early on. So looking at these initial labs and her EKG here, so as you can see here, this was her initial VBG. We didn't have an ABG at that point. Met hemoglobin was 56%, CO was 0.6. She had an ethanol of 216 and a lactate of 6.8. Everything else, not terrible. So looking at these labs here, what would you say is the most critical finding here? So for some little participation here. Put it in the chat. Yeah. Yeah, so the met hemoglobin for sure. Lactate for sure, pH. In this particular case, since we kind of had the inkling this was a sodium nitrite ingestion just based on the story, things like that. So as we're working up this patient, we had that background. Thankfully, we, got a VBG and an ABG as soon as possible to get that met hemoglobin level. Ours come back within like 10, 15 minutes at my institution. We called our toxicology team. We do have an on-site toxicology team. And then we don't have methylene blue, or we didn't have methylene blue stocked in our ED Pyxis machines or automated dispensing cabinets. So we had to get it from Main Pharmacy, which is across the hospital. So thankfully, I had another pharmacist on with me, and I sent her running to get the methylene blue as we were working up this patient. So this kind of brought up an interesting scenario for our ED docs versus toxicology and pharmacy. Based on these case details, what would you prioritize as your first intervention for this patient? Would you RSI her first, or would you prioritize the methylene blue administration, even though she doesn't look that well? She doesn't look like she's really protecting her airway. Her GCS is 7. How would you prioritize this? Because this was definitely something that was discussed in depth between everybody after this case. Yeah, so it looks like I got some answers. Prioritize your methylene blue for sure. Yeah, absolutely. So I agree with that. And kind of that's why I wanted to present this case is, a lot of our ED docs who weren't really familiar with, the nitrite ingestion and all of that, they see this patient, GCS of 7, she has terrible color, she looks terrible. They want to secure that airway. So that is kind of what they prioritized, and during that prep for RSI, we were kind of able to start facilitating that methylene blue, administration. So methylene blue is the antidote for nitrite toxicity. So it's an oxidizing agent by itself, but in the presence of certain reductase enzymes, it is reduced to leukomethylene blue, which then that acts as a reducing agent. So that reduces your met hemoglobin back to your normal hemoglobin. So you're able to have the oxygen carrying capacity. RSI, is going to provide that supplemental oxygen. It's going to protect the airway, but it's not really treating that underlying mechanism of toxicity, which is kind of where that pitfall was for our ED docs and some of our other, physician colleagues that were at bedside is, they're like, we got to take the airway. We got to take the airway. And Tox was like, where's the methylene blue? Where's the methylene blue? Where's the methylene blue? I do think RSI has a role in these patients. It's helpful to facilitate other care. And especially if you don't have bedside toxicology, it's helpful to get to that, RSI, protect the airway, and call your poison center at the same time. So there was a lot of multitasking going on with this case, which I think is, again, really important. And overall, methylene blue should be prioritized intervention if it's feasible and there's no contraindications to its administration. So just a little bit of pathophys of sodium nitrite-induced methemoglobinemia, pathophysiology. So nitrite oxidizes your ferrous hemoglobin into ferric hemoglobin, which is your methemoglobin, and that has no oxygen carrying capacity. So your hemoglobin, your blood can't carry any oxygen, and there's decreased oxygen delivery to your vital organs. So that is kind of why you see that pronounced cyanosis. Again, key presentation factors. Cyanosis is probably the bigger one. I know that can also be seen in other disease states as well, but the amount of cyanosis this patient had and still had a pulse was something I've never seen before. We all kind of thought she didn't have a pulse when she rolled through, but she had really like deep blue discoloration. You saw her foot picture. So that is something that can maybe kind of hint you if there's like this blue tint to the patient. Maybe it's not just, an airway issue. Maybe there's something else going on. Low oxygen saturations. If your patient is still, kind of with it, they can have dizziness, headache, fatigue, and then it kind of gets that CNS depression and your death. It's been reported that methemoglobin concentrations greater than 70% results are fatal. There are a few case reports of patients surviving if they get treatment immediately, but that is kind of the general thought out there. Another key thing is your general SpO2 reader, the one that you stick on the finger or the ear for a better reading, is unreliable in this disease state. So you have to use a co-oximeter for accurate readings, or if you're looking at your O2 from your VBG or ABG, that's going to be your most accurate reading. But that is something to keep in mind, especially, which I'll talk about in this patient when we RSI'd her. We're like, oh my God, her SAT's not getting better. Her SAT's still 60%. Like what's going on? Like, is the tube in the wrong spot? Things like that. So just remembering that normal SpO2 that we rely on is not going to function as it should in this case. Treatment of it. So methylene blue, as I talked about, 1 to 2 mg per kg IV push over 5 minutes is what we did. They recommend that you can repeat it in 30 minutes. Another important point is that when you administer methylene blue, it's going to transiently decrease your SpO2. So if you are looking at your SpO2 monitor and you kind of start seeing it downtrend and you're thinking, oh my God, she's getting worse, that is a common thing that happens with methylene blue. And you just kind of have to wait it out for about 10, 15 minutes, and then you'll start to see that kind of subside. So if methylene blue doesn't work, what do you do? So the other two options that I read in the literature is exchange transfusion, which we were setting up for this patient, and or a hyperbaric oxygen therapy. It may be helpful. The benefit's not 100% for these, but that is your kind of next line. If you don't have those options at your institution, so this is kind of brings me back to the point of you may not have bedside toxicology, you may not have the resources you need. That may be a point where you're talking to your poison center, get your recommendations, hopefully stabilize the patient and transfer them to another hospital for a higher level of care. Whether or not that's feasible, I'm not 100%, but that is kind of, I think, your only option at that point. So key interventions. So as we were performing RSI for this patient, we were facilitating getting toxicology down at bedside, and the methylene blue was being picked up from the main pharmacy. Once the patient was RSI'd and the methylene blue was administered, Tox actually recommended a gastric lavage. It was a pretty good story that she had ingested this in, about an hour before she was found. So they were like, let's do it. So essentially we have a 32 French gastric tube that they used with sterile saline irrigation. So essentially they set this thing up and then they kind of like push and pull. They fill the gut with, the sterile saline, and then they pull it out into the irrigation bag. So they did that for a few rounds until kind of the irrigation was, looked like just saline. So that was pretty cool to see. Again, that may or may not, help the patient because a lot of the times it's like a powder or, a liquid that the patients are ingesting, but something to be considered. After that, there was concern for co-ingestion for this patient with some other tablets. So we did do activated charcoal after the gastric lavage was complete. And as I mentioned, so we administered methylene blue 1 mg per kg over 5 minutes times 1. We did repeat that 1 mg per kg about 10 minutes later, just because toxicology decided that they wanted to do an upfront 2 mg per kg dose instead of 1 mg per kg because of how sick she was. So she got about 2 mg per kg in about 15 minutes. And then about 30 to 45 minutes later, she was improving, but not as well as toxicology wanted. So they wanted to do another 2 mg per kg of methylene blue instead in hopes to avoid the exchange transfusion because that was something that was being worked on as we were waiting for the response. So in total, she got 4 mg per kg of methylene blue IV push. So then we repeated labs. And then, so this was the result of the gastric lavage output. So it had this green fluid with like powder-like crystals in there. So we were able to get some of what she ingested out. Again, we had a pretty good story that this was a pretty recent ingestion. Powder liquid ingestion, it may or may not be beneficial. We were able to facilitate this pretty fast. So, and then looking at the 4 mg per kg of methylene blue, the patient color returned, as you can kind of see the initial picture, turned into a normal looking color for a patient. And she ended up having a normal O2 saturation as well. Follow-up labs. So this was follow-up labs for her. So her second hemoglobin we got was 9.1, and then it kind of down titrated down to back to normal. Her EKG normalized to normal sinus rhythm. Her lactate was still a little bit elevated at 3, but steadily coming down. Gas normalized. So she was looking pretty well at this point. So what happened now after that? So patient was admitted to the ICU. She did not require any further methylene blue. She was able to be extubated the following day. She did express to our toxicology team that she had ordered the sodium nitrite kit off of Amazon. And so she kind of confirmed what we treated. She did have some mild serotonergic symptoms that did not require any treatment. As we know, like methylene blue kind of functions as like an MAOI. So it can have pretty serotonergic effects, especially at higher doses. And she got 4 mg per kg in a relatively short time frame. So that was something we were monitoring, but thankfully it didn't progress to anything that required treatment. She was then discharged 3 days later and had outpatient psychiatric follow-up. She didn't have any like long-term effects from, the poor oxygen delivery she was experiencing. So she had a really great outcome. So clinical pearls to talk about prompt recognition of this toxicity is imperative. I know we say that about pretty much any emergency that we have, but cyanosis and persistent desaturations are key findings. Other findings are kind of non-specific, but kind of having this whole picture together may help you get there. Get them at hemoglobin level as soon as you can. Like I stated earlier, greater than 70% is reportedly lethal. There is survival reported in about 90% of cases, again, with that prompt recognition and treatment. Methylene blue administration should be prioritized over, other interventions such as like RSI that are not going to treat the underlying cause. 1 to 2 mg per kg over 5 minutes. You can repeat that in about 30 minutes after. And then, why did I bring this up was another big point as well. So this was the first one I had seen in my career, relatively short career. But there's been a steady increase in sodium nitrite ingestions. It's becoming more and more common. This was National Poison data reports looking at intentional ingestions from 2009 to 2019. So through that time period, they had 17 reported to them. And there were 4 in 2018 and then a big increase of 13 in 2019 and 41% mortality rate for those cases. So we know it's becoming more common. It's easily obtainable. So it's a commercially available coloring agent, food preservative, and medical agent. It's highly effective for what people are using it for. And it's also gaining popularity from online blogs and discussion posts. So there's like a big Reddit thread about this, which, kind of can influence some of our younger patients of, who are trying to commit suicide, that they're seeing that this is working, you should do this method. It's easy to do. It's cheap, things like that. Something to pay attention to. And then another thing, a pearl that I recommend if you have methylene blue available is to add it to your automated dispensing cabinets in the ED. So our, acquisition of methylene blue was about 15-20 minutes to get it to the bedside to administer to the patient. So we were able to put that in our trauma bay Pyxis or a critical care bay Pyxis. So we now have that at bedside, which thankfully we did, because 2 days after we had this case, we had another case that was not nearly as bad as this one, but another ingestion, similar situation. So we were able to treat that one, a little faster than we did. Again, administration should be done at the direction of your poison center or your toxicologist, if possible. So just to wrap it up, sodium nitrite ingestions can be recognized by profound cyanosis. Nitrite induces toxicity by oxidizing ferrous to ferric hemoglobin, causing your methemoglobin. Can't have any oxygen delivery to tissues in that situation. Your SpO2 is going to be unreliable. So if you RSI them and you're expecting their SAT to go up, it's not going to. Call your poison center as soon as possible or involve your toxicology colleagues as soon as possible. Methylene blue should be your prioritized intervention if it's feasible and there's no contraindications. And again, I recommend adding that to your automated dispensing cabinets in the ED if that's something that is able to happen at your institution. All right. So we have our first assessment question. So which laboratory finding is the most critical in a patient presenting with cyanosis and altered mental status after suspected sodium nitrite ingestion? All right. Looks like we're getting B's all around. Absolutely. So methemoglobin is going to be the one that's going to be your most critical. So again, most critical laboratory, it's directly measuring the extent of toxicity. So again, in the case I just presented, we had a level of 56%, which was, again, highlighted as the most critical finding and really kind of, confirmed that suspicion we had for diagnosis. Elevated lactate, secondary finding due to tissue hypoxia, metabolic acidosis. Again, poor oxygen delivery, not the primary problem. Elevated ethanol was a coincidental finding and not related to the primary toxicity. Assessment question number 2. What is the mechanism by which sodium nitrate causes toxicity? All right. Yep. Everybody's getting this one too. So again, B is going to be our answer. So oxidation of ferrous to ferric hemoglobin. So that is correct. So that essentially just converts our hemoglobin to methemoglobin, so you have no oxygen carrying capacity. Cytochrome oxidation inhibition is cyanide poisoning. Oxygen displacement is carbon monoxide poisoning. And direct membrane damage is just not the mechanism of nitrate toxicity. Okay. And then these are just kind of like overall discussion points we had in this case. So I think the big one too, like we kind of talked about, the findings of this are kind of non-specific, but what other conditions may be presenting similarly to this that may, kind of lead us astray and kind of lead us away from sodium nitrite poisoning, especially because that's not something that's like, something we see every day. Feel free to unmute, discuss.
Liz, was that second case, was it kind of like a Me Too, or did the person do it because they heard about the other one, or was it completely unrelated, the second case that you had?
It was actually completely unrelated. Like I said, I think there was some sort of discussion post going around because it was another, younger patient. I think she was 18 or 19. So I don't know if maybe there was like communication outside of the hospital, but as far as we could tell, there was no connection to the first case. It just happened that this person also decided to try to commit suicide using the same method.
It, no, I have a couple questions about the case, Liz. I think you did a nice job. I don't mean it that way. There are cases that are of interest to me personally.
Mhm.
Um, the dosage form, was this a powder or a tablet?
That she ingested, it
Yeah.
was a powder.
Powder. And
Mhm.
how long after the ingestion itself were they able to actually lavage the patient?
I would say probably within an hour, hour and a half,
Okay.
that
Did you
they were
get
able to
to,
actually start lavaging.
and did you get to watch the procedure?
I did, yeah. It was pretty intense.
Okay. Would you describe it as a simple, easy procedure to do, or did they struggle a bit?
Yeah, no, it definitely was not simple. And I think the only reason it went so smoothly is because our attending toxicologist was at bedside, mostly doing it himself. But we actually have a little kit. We have a whole bowel irrigation kit and a gastric lavage kit in our critical care bay. So that was
Oh,
helpful for
nice.
materials we needed.
Yeah.
Yes,
Yeah.
he was
And
able to
Jess
kind of
Rivera
facilitate
in chat is asking if you had an E-wall tube. Those are bigger than the 32s. Those are 40 French. Those would be preferred if you have a, oh, stop yourself, John.
that.
Back in the dark ages when we did this all the time, you could see an R1 or an R2 dropping. We did it all the time. We averaged work day on the weekends, it went to 8, but work weekdays, 6 lavages a day during day shift in the 80s. It was just considered any suspected ingestion, you did it. And people could do it within 10 minutes max. I mean, it was fast. And nowadays, when it happens, I just see people waste 10, 15, 30 minutes, which in my era, it was not saw. It was ER or whatever the new one is that I can't think of the name of right now. And maybe for John, that young man, it's Saw, because anyway. And the last, and if please, someone else. Yes, I did, Brian. And you
Frank,
know
I
what?
have a
But
Frank, I have a
I've had,
question.
there have been times in my life where I didn't when we were in South America. So don't start arguing with me, Mr. Pampered. But, and what was the choice for 50 grams of charcoal? Do you have any
Honestly,
idea? Yeah.
oh, I'm pretty sure the 50 grams was just the tube we had. That's our like standard is like a 50-gram tube, so they just ordered one of the tubes.
And for us, we see a lot more nitrites. I'm really glad, it's a relevant topic. We
Mhm.
still have many more of ours are the amyl nitrates. We
Mm.
still have a lot of fans. I don't know what else to say. Yeah. I'll stop now. I'm sorry, everybody. You shouldn't have started with tox.
I had a quick question,
Okay.
Yeah.
Liz.
Uh-huh.
Thanks for bringing up this topic. This is, like Frank said, just so relevant, and I'm glad you presented this very interesting case.
Mhm.
And actually, I would like to hear Frank's opinion too. But did y'all discuss in your debrief with it being a powder formulation? I know you mentioned gastric lavage perhaps not necessarily being beneficial for a powder or a liquid formulation, but any discussion on if that could have potentially put more into dissolution? And with your toxicology service not being as pleased with her initial response to the methylene blue, if there was maybe any just discussion around that? I'm just curious.
We actually, I haven't heard discussion about that, but now that you bring that up, that is a great point and definitely something I'll ask our toxicology team because I didn't even really think about that. That could, with it being a powder form, that could potentially increase absorption of the nitrite. Yeah, we actually didn't talk about that.
You're caught between a rock and a hard place there. Okay, because you
Mhm.
don't know if there was enough fluid in. Jess, I think, is what she's trying to push a button here. We don't know what these things. We don't study how much dissolves how quickly. Yeah, Brian, I don't disagree. I've already given her some hints as a reviewer might as to what she could do to play with it a bit. But I think I don't know if, without knowing how much powder she claims to have ingested, it would be, you can't guarantee that, like when we do the volunteer studies with small amounts of known to dissolve in people powders that would have all dissolved, and lavage won't work if it's a solid material. It just doesn't work very well unless it's tiny. And be careful, Liz, your crystals in your urine that you got, um, not in the urine, in the lavage, that
Mhm.
lavage fluid, those were white powder, white something, fine. You need to actually ID it to be confirmed that it was the sodium nitrite and maybe not something else that was an excipient or something. Does that make sense?
Yeah.
Don't speak so,
Matter of fact.
yeah, not quite that emphatic. Suggest
Yeah.
that we didn't touch. You make your case report look better.
Yeah.
Yeah.
Cool. Thank you. All right.
Please don't have the second one be tox.
And you can still, I just did it because I was curious. If you go on Amazon, there's still some shady stuff that looks like sodium nitrate that's still on there, but it says you have to create a business account, but I'm pretty sure it's probably easy to fake. And it's 99% pure, by the way.
Thank you, Liz. We'll move on to the next topic, and Frank, this is probably still tox. It's an element of PK, which is maybe related to tox. So for the next presenter, we're going to have Aubrey Baker, who's from Grady Health System. She works with me. She's completing her PGY2 emergency medicine residency, and she's going to be talking about what is the dose of rocuronium.
Okay. Thanks, Sean, for that. Y'all can see my slides. Okay.
Yep.
So to set the scene, you're in an emergency room, have the radio next to you and it goes off. The alert coming in is a 79-year-old female. That's a stroke alert arriving via AirEvac. It's noted that she's intubated due to low GCS and unable to protect her airway. And then her last known well was the prior evening. Okay. So once she gets to the hospital, you go bedside due to her being intubated, talking with the AirEvac team. And it's noted that she was intubated with 30 milligrams of etomidate and 115 of rocuronium. And this was administered about 30 minutes prior to arriving. Her actual body weight is 90 kilos, and that's about 1.3 milligrams per kilo of her body weight. And no sedation is currently running, but AirEvac noted to administer Versed and fentanyl prior to coming down from the helipad. So you obtain the CT head and it demonstrates a large ICH. And then AirEvac also mentions that she had a past medical history of AFib and she's on warfarin. And then her point of care INR came back 2.8. So the team overall starts having a discussion on if we should start sedation or if we should consider reversing the paralytic agent. With a quick showing of rocuronium versus succinylcholine demonstrated in this chart, the head-to-head data that shows it's really mixed, showing that some are no difference between the two at first pass rates or desaturation rates, but the other half showing that succinylcholine actually may have superior intubation conditions or a better first pass rate. So for a quick poll, what dose of rocuronium does your institution mainly see? And like this could be a discussion for afterwards too. A, 1.2 milligrams per kilogram, B, 0.6, C, 1, and then D, whatever the provider wants, like a good pharmacist. Okay.
Looks like most people are C, and some are C and A.
Okay. So I'll say here at Grady, we use or try to tend to use 0.6 with a max of like 1 milligram per kilogram if they're a little bit smaller. But AirEvac use about 1.3 milligrams per kilogram. And then when looking at the average duration of rocuronium, it's very pharmacokinetic dose dependent. So your larger doses are going to have a longer duration of action. So this 1.3 could be 60 minutes or higher, but it's really unsure. In addition, dosing with ideal body weight when looking at rocuronium has overall been found to be non-inferior when looking at ideal body weight plus 40%. So this table overall looks at obese patients versus normal weight patients, with the overall included patients being a little bit lower in each study. But they overall found that these obese patients may have a longer duration of action with the rocuronium doses. However, one did find that it may not prolong recovery to spontaneous recovery. And then this chart overall shows that dosing these obese patients with actual body weight versus ideal body weight. That ideal body weight overall had a shorter duration of action and that it did not compromise intubation conditions when using actual body weight in these patients. Overall, concluding or going to my conclusion that using ideal body weight may be preferred in some of these obese patients due to it having a shorter duration of action and potentially leading to faster neurologic exams in these patients with an ICH. But this patient was dosed with their actual body weight. So looking at the clinical course of this patient, the team decided that the patient was still paralyzed and that we should start sedation. So continuous sedation drips were started prior to us calling neurosurgery. Once on the phone with neurosurgery, they requested the usage of Sugamidex prior to their arrival and to turn off all sedation. However, in our emergency department, we do not have a policy for reversal of paralytics, so Sugamidex was not available or neostigmine at this time. So a quick poll, overall, does your practice site have a protocol or procedure for reversing the paralytic agents? Oh, it looks like no, a lot. Okay. So looking at her clinical course, neurosurgery, due to this information, decided to get a train of 4, which has been considered the gold standard of monitoring reversal. It has been noted or some thoughts about clinical strength. So having sustained strength of greater than 5 seconds in an extremity may be more better practice in the emergency room due to not having to train staff or have a machine. So we ultimately decided to get the train of 4. However, the layout of our emergency room, the train of 4 was in a different department or segment of our emergency room. So we went and got it, brought it to the neurosurgeon for them to use. However, it came out that they weren't sure how to operate it. So then we went to find a nurse on the other side where it usually is. They came over, looked at the machine, saw it didn't have batteries and couldn't be used because it didn't have the battery. So then about 20 minutes went by for us to track down batteries, use the machine, and then the train of 4 came back to be 0. And this patient, so she was either paralyzed or had already herniated. So then I was going to talk a little bit about agents to reverse rocuronium, with one of the older ones being neostigmine and then the other being Sugamidex. So overall, neostigmine has ceiling effects. So using the dose of 0.07 mg per kilogram or max of 5, due to it not being able to effectively reverse deep levels of paralysis, really those 3 and 4 levels, where this, or 2, 1, and 0, where this lady was at. And then looking at the pharmacokinetics of Sugamidex, the overall half-life is about 2 hours, and then this can be prolonged with patients with renal impairment. So if you were to reverse this paralytic, they had renal dysfunction, and then you decided to paralyze this patient, you would run into potential problems with the usage of rocuronium again. In addition, the package inserts has 3 different doses with 2 milligrams, 4, and 16 milligrams per kilogram that can be used for rocuronium or vecuronium. However, the 16 milligrams per kilogram is only suggested with rocuronium and not vecuronium. And then one study did look at specifically patients in the emergency department and went head to head with 2 milligrams to 4 milligrams per kilogram. And overall saw that the reversal of these two were relatively the same, and that 2 milligrams per kilo was just about the same as 4, and that these also facilitated neurological exam in the emergency department. So to summarize, low dose or 0.6 milligram per kilograms of rocuronium is adequate for intubation and lower duration of action in obese patients, and that there's limited situations to the usage of Sugamidex in the emergency department. So the first assessment question, which method is most reliable for assessing neuromuscular blockade recovery? Yeah. So a lot of the answers look to be B. So yes, the Trina 4 is the most gold standard for monitoring the Trina 4 compared to clinical scenarios. Okay, next one. What is the appropriate Sugamidex dose for moderate neuromuscular blockade reversal? Yeah. So it looks like most of the answers in the chat are 2 milligrams per kilogram. So yes, that is correct. So that's used for the moderate neuromuscular blockade, whereas 4 is for deep and 16 is for the immediate reversal. So now I'll open the floor for discussion or any questions about this case.
So Aubrey, in the presentation, you talked about neostigmine. Would you have used or would you have recommended neostigmine for this patient?
I wouldn't have in this patient due to her being a Trina 4-0, so it wouldn't have been, it has been found that the deep paralysis of this patient with neostigmine reversal wouldn't have been as effective as spontaneous recovery.
Hey guys, I think for this one here, for like developing a protocol, one of the things I like to try to do is stock neostigmine, but also have a secret stash of Sugamidex somewhere that can just happen to be around. So that way, if we know we're gonna do all of this, my thoughts is if I reverse them quickly, then I can turn around and get that on board, get the neostigmine on board. It's cheap. No one's gonna ask me any questions about that and with the atropine, of course, and then turn around and by time neurosurgery calls and we call them, hey, we've already reversed them. And depending on your shop, how quickly they get down there, we can kind of have that process done. And I realize it's not the superior, but looking at the chat, it looks like people are just not going to be able to get that most of the time. So I want to hear what you guys' thoughts of that, of just kind of having the cheap version available quickly and then having the big gun put away in case you need something right now. I really want to see what you guys think about that.
I'm cool with going that route, but I might have to send like a carrier pigeon to find neurosurge though.
Yeah, I feel like we've done that with other things, but our pharmacy leadership is very stuck on the price of Sugamidex. Our hospital used to restrict it specifically to OR use only, like our neuro ICU couldn't even use it until one of the neuro ICU intensivists like freaked out on our management. So that is the only place that is routinely allowed to use it outside of the OR. Obviously case by case based in the ED. I kind of mentioned in the chat, my kind of thought about it is we can get it from our main pharmacy like relatively quick, like 10-15 minutes. But my thought is if it's not going to change whether or not they're going to the OR or some sort of immediate intervention they need to make right now, I just tell them you're gonna have to wait for your neuro exam then. Like unless this is going to decide the patient's intervention status, like you're gonna have to wait and come back or something like that. Or if we know it's like a stroke patient that we're tubing, neurosurgery responds to all our stroke alerts, so we make them evaluate before we tube them. That's another thing that we also try and do if they're available.
Question for you guys. So we had a case somewhat similar to this, and one of the barriers that we ran into was when we did train of 4 testing, we didn't have a baseline on the patient. So we didn't know if the power wasn't high enough or if that just or if she was truly a train of 4 of 0 and the rocuronium was still on board and not getting cleared out. I was curious if that's something that you guys have run into before. We have our train of 4 available in the ICU as well as Sugamidex available in the ICU. And that was kind of the discussion point is, do we use Sugamidex? Do we restart sedation?
Yes, the team ultimately decided to restart sedation due to her having a higher BMI. I think her BMI was like middle 30s. She was ultimately transferred to our neuro ICU where they have nursing that's more trained on the administration of Sugamidex. However, after her transfer, the team decided, or neurosurgery decided not to administer Sugamidex due to saying that it was a devastating head injury due to her midline shift at that time. So yeah, I hope that answers your question.
And I would add to your question too that we don't do that typically as a routine, getting a baseline. I think it's a good idea, but I think people, whether or not we have the time in the emergent situation to do it, but other cases where we've had people get doses of 2 milligrams equivalent per kilo or higher than 2 milligrams per kilo, they didn't get a response, and then they waited longer thinking that it's probably still. So I think that's kind of the thought. If we don't do the baseline and it doesn't work, then maybe you just have to wait a longer period of time. But that's a great point about getting a baseline.
That's reasonable. This patient happened to be up in the ICU by the time that we were trying to determine if the rocuronium was still on board or if the patient just had a devastating neurological injury. So that's kind of why I was curious for places that use Sugamidex more frequently in the emergency medicine to ICU setting, how you account for that when you're not necessarily going to plan on reversing them.
For you guys, it's like in the community setting, do you guys feel like you have get access to it as far as getting Sugamidex, or you guys feel like that's something that's a little different? I feel like sometimes the difference in the academic and the community shop depends on how stringent they are. I just want to know, again, for some of you guys that are at community or even a smaller academic shop, what you guys practice, and as far as how easily can you get Sugamidex?
Jimmy, it's Sebastian. So first and foremost, I don't think my doctors even know what Sugamidex is. And I don't think our neurosurgeons know what Sugamidex is because they still love mannitol and they still love giving platelets and all the shebang. But our OR loves it. I'm actually on a subcommittee corporate for drug cost reduction. And Sugamidex is literally #1 in our entire hospital system for decreasing costs. So it's literally an active thing by corporate that we want to reduce its use in general in the OR. And so to even think to suggest that I want to use it in the ED will be like, you're nuts. So it's not even like a thought.
We got any peds people on? I'd love to see their thoughts on this. This is a completely different aspect.
Another question I had is if anybody's looking at using a lower dose, that maybe if you don't give this high dose, maybe it'll be worn off by the time, if the patient's already a GCS of 3 or unresponsive, maybe you can use a lower dose. Curious if anybody has tried that or found that to still be successful with RSI conditions.
John, there was one case that when I was working one of my PRN jobs that we were pushing the Sugamidex, like we pull up the 2 mg per kg dose, it pulled up in the syringe. And while the nurse was pushing it, literally, like, I don't even think she pushed like half of it. And the patient like started like waking up and started like literally like full out like almost standing up in the bed. Like we just like gave him Narcan. Like it was pretty crazy. It was pretty crazy to see, but it was, yeah, I think it ended up being like almost like a little bit less than 1 mg per kg. But it also was later after RSI, so maybe it was just some lingering rachydermium and still wasn't like the full amount. But good question though.
Yeah, definitely off the books or more creative thinking.
Yeah, Aaron, that brings up a good question. If you have access to it, do you want to wait to after CT to give it? Because they once they're up, they're really up. I wonder what you guys' thoughts was on that because I make sure they're sedated, make sure they're well, and usually by the time we get to CT, the sedation and all the things we have on board are still there. But I want to get that good scan.
I don't think, well, in my shop, which I don't own anymore, but and we never got that many of these cases, to be honest, just because County is next door, and Northwestern and U of C are so close. But that's the kind of decision that depends on the given day. How many people are already backed up trying to get into head CT? I think it's awkward to have a specific policy for that personally.
I have a separate curveball I want to throw everyone. Has anyone had used the Gamadex in a myasthenia patient?
I don't think I've seen more than 10 acute myasthenics ever in my life in the ED. I am completely ignorant there. Insert Brian Gilbert comment now, please.
We have a decent myasthenia population at my institution. We have one guy that comes in like every other month and gets intubated, but we've never used Sugamidex for him. We usually do the 0.6 mg per kg of rock for him instead of 1 mg per kg. But that's generally our thought there, but we haven't ever like reversed their paralysis or anything like that.
$500. Yeah.
And Jessica's talking about the large patients. That's usually where we run into problems with
Yeah.
people not capping the dose. A lot of people did talk about capping the dose at 100 milligrams, but we ran into some of these really high doses.
So during COVID, we capped at 100 milligrams due to concerns of ongoing shortages and access to medications. And we were able to continue that afterwards because our docs don't know the difference after a couple of years of why we cap out at 100. We were also looking at, whether or not the ideal body weight in some of the previous literature, we could kind of lean on that a little bit. So when they're asking for 1.3, I'm like, really, at the end of the day, if I'm using ideal body weight, they're getting around 80 to 100 anyhow. So that was kind of some of our thought process on that, trying to just conserve drug during the pandemic.
Yeah, definitely great point, and use it even for non-pandemic, same ideas, but good point.
Have any of you guys seen even like higher doses than 1.3? I know especially our anesthesia folks will sometimes go up to even like 2 mg per kg of rock. And I know I haven't seen any literature to necessarily back that up, but I was just curious if any of you guys have been seeing super therapeutic rocuronium doses at your shop.
We've been seeing some that are driven by, I think, like some of the social media medicine that, double the dose of rock and half the dose of your sedation, which hopefully I'm never a patient there.
That's our normal anesthesia. They give no more than 10 of etomidate, and then they hit everybody with at least 100 of rock.
Anesthesia voodoo.
Okay, good. It's not just me that has beef with anesthesia.
I have lots of beef, especially when I occasionally have to go to a code in the floor and they're there.
Well, thank you everyone for attending tonight, and thank you, Liz and Aubrey, for being the first people to present at the session. There was definitely a lot of activity in the chat, as always, which appreciate, and keep that going throughout. Also wanted to thank Jimmy and Louisa for helping in the background with all the technical and managing the Zoom and all the technical support from both of them. So for your CE credit, please submit within 30 days. The code is listed there. So that would be July 5th to submit it by. Go to the empharmacist.org, log in, and then you can select the EM Pocket out of cases, complete the assessment questions, then also fill out the feedback form to be able to get your CE. So again, watch out for the next, we'll be sending out an invitation for the next session, which will be Thursday, July 10th at 7 p.m. Eastern Standard Time. And please submit cases. You know, I think these are good cases. I'm sure everybody has some great cases that they can think of. Sometimes it might not be a new drug, but just a different presentation, or maybe kind of something gone wrong, and how did you mitigate that case. So please continue to submit your case submissions. We plan on doing this every month. And also don't forget about the town hall next week, June 11th. And thank you for joining us, and we'll see you next month for the cases on July 10th. Thanks, everyone.